So I'm Jason Astrin. I'm the Director of APP Services for the US Oncology Network. I also serve AppShow on their board of directors, and so always my plug for AppShow. If you're in the audience or whether you're live or at home and you're not an AppShow member and you're an advanced practitioner, please consider joining AppShow. We're trying to really create the position where AppShow is kind of the premier society serving the needs of our advanced practitioners, which includes pharmacists. So my role as the APP director within our network, we have about 600 APPs scattered across our network, and my job is I spend a lot of time working on just this, like answering practices questions on really where the value is with our advanced practitioners, why do we hire them, how do we onboard them and utilize them, and how do we really demonstrate that return on investment. And so in the short 20 minutes that we have, we'll go over a couple of kind of some background information I think is necessary when we talk about productivity versus value, and then a couple of points around kind of what we're working on and some hopefully some pearls for you guys to take back into your practices. And so, and by the way, we title this productivity versus value because they're really two different things, right? So when we talk about productivity, a lot of our APPs are traditionally measured based on their productivity, based on the direct revenue that they bring in to the practice. And that's not necessarily probably the best idea, I think, on how to value an APP, and hence we use that word value more than productivity. And so I work on things in our network where we apply dollars to things that the APPs provide that's valuable but may not necessarily be productive from a revenue perspective. And when we really think why, if we step back even further, is why it's important, and we'll talk about this a little bit in a few minutes, but the fact is that there's an oncology shortage, which all of you recognize and probably see. Some practices still struggle with recruiting oncologists to locate to their, maybe it's a small community, small town. Way back in 2007, ASCO formed this workforce advisory group, and you see they made a number of recommendations, and a lot of them really do apply to advanced practitioner. Of course, number one was to increase the use of the advanced practitioner and really develop an opportunity and develop process in the practice to, whether it's offloading more patients to an advanced practitioner, develop programs that the advanced practitioner can lead. Offloading care of survivors from medical oncologists, certainly some of that could apply to the APP world. Also probably means a lot of primary care and internal medicine involvement. We certainly can improve the efficiency of care that we deliver, and could that help in an era of physician shortage? And certainly, and I think another reading between the lines, another opportunity for successful APP practice, which certainly can make physician practice more efficient. Or we could just take all our fellows and say, guess what, you're going to work in this era of shortage, and you're going to burn out, and you're going to be busy, and you're going to not have an admin time, and you're going to work through lunch and stay after work and things. And so really what happens when you don't really fully realize the value of an advanced practitioner, and just a couple of stats. One is from a missed opportunity around profit and productivity. And so when a practice, and I just did a kind of a crude calculation looking at a 99213, right? Physician sees a 99213, an APP sees that 99213 doesn't bill incident 2, so we're getting reimbursed at 85%. And if we look at the cost of those providers from an overhead perspective of being in that visit, let's say it's a 15-minute visit, every time a physician sees that 99213, you technically lose about $50, right? You're going to get 100% of that reimbursement, but it costs that physician a lot longer of his 15 minutes. It costs that person a lot to stay there 15 minutes. I'd rather that physician see a consult. I'd rather that physician write chemo orders or put patients under the beam and radiation or take them to the OR, depending on the specialty. We looked at our network. We have about 2,000 medical oncologists, and we looked at the total work RVUs from the oncologists, excluded the work RVUs that were tied to the APPs they may or may not work with, and we found on average our medical oncologists are earning themselves around 2,500 more work RVUs per year when they use an APP. And that's not APP work RVU added in, that's the fact that we've allowed the physician to do things that earn more work RVUs, right? And we can convert 2,500 work RVUs to about $33, $34 per work RVU, and you can figure out the financial implication there. And that's one tool to think about when we're valuing APPs. Some of our APPs, if you track them on a spreadsheet and you're looking just at their direct revenue, they have a negative return on investment. Some of our APPs do not cover their salary and benefits for whatever reason. They're working in a subspecialty, they see a few patients because maybe they're doing palliative care, that takes a little longer. But if you can add to the fact that, okay, maybe there's some loss from their direct revenue, but the physician that's paying for that APP was able to earn 2,500, let's say on average, additional work RVUs, we've offset clearly that loss. And that's like, that part sometimes does not get into the spreadsheet when we're looking at how we value the APP. And then of course, if we don't value the APP and they recognize that, then they're gonna go. And of course, some of this data was pre-COVID, and you can imagine post-COVID or still in COVID. Our APPs, I said about 650% in a survey I just provided to them, asked them to complete a few months ago. 20% are burned out, and 50% are burned out, and about 20 to 30% are out of there in probably the next 1 or 2 years. And we've had the great resignation, just like probably you have in your practices as well. And of course, it costs money not having an APP. So turning over an APP causes about a $1,500 loss per day in not having that provider sit there. And of course, turning over an APP, which I've heard from some of our practices say, oh, we have APPs applying all the time. That one will quit, we'll hire a new one. Okay, well, that new one might be a new grad, probably needs to be credentialed, probably needs training and ramp up. So you're looking at probably a couple $100,000 in just turnover costs every time you turn over an APP. Another thing that I try to talk about a lot when I'm talking to our practices and outside of our network is really how do we evolve or continue to improve the role of the APP. And number one, this most definitely adds to their value. So you see the status quo, and it's becoming less status quo, by the way. So a lot of you might think, well, we already do kind of this new model, which is probably not a new model, but I think it's the preferred model. So the status quo model was the physician has kind of a dependent APP where Monday morning a schedule is printed and the physician and the APP kind of huddle around that paper schedule, and the physician says, you're going to see, my 8 o'clock and maybe this 9 o'clock, and we both need to see this 10 o'clock, and maybe you can see this 11 o'clock maybe, which is fine, and it allows the physician, traditionally to have this big mega clinic schedule, and you can kind of divide and conquer, but the physician often participated in that visit also. So now you have two providers seeing the same patient, which from a cost perspective probably isn't the best idea. And I'm not saying we don't want our APPs and our physicians to collaborate, but I think when the physician kind of owns that schedule and determines the APP role in the visit, that you're not capitalizing on the value that the APP can provide, which is, why do you have, as a physician, 15 follow-ups on your schedule when you're trying to get new patients in it takes 3 to 4 days to see, or maybe the heme business that tends to always go in the back burner sometimes, and they're maybe out a couple of weeks. Why not offload those follow-ups right onto the APP schedule? Keep them busy, keep them down the hall, have their own nursing staff, their own exam rooms, and then they'll collaborate with you throughout the day as needed, and so you're really seeing double the work of which you as the physician shareholder, owner, employer, partner is really capitalizing on as well, but you're able to see those new patients. So that kind of newer preferred model is that you have this more autonomous team, and that increases obviously the value that the APP provides when they're seeing patients independently. And then briefly, we hear sometimes that there's pushback to that argument, right? Because I've heard almost all of these from the medical oncologists I work with and other surgeons and rad oncs, is number one, I don't want to lose patients. The APP is going to take my patients. We're not trained to be able to handle the same types of patients I handle. Or the APP is going to provide the same quality of care that I do as a medical oncologist. And I added this kind of should they or should not or should have kind of the same voice in the group as physicians, which we'll talk about in a second, which is a big point. But I think all of those are valid discussions, and I think having those frank conversations with the physicians, with the APPs together, the APPs aren't out, they're not going to hang up a shingle across the street and take your patients and move them to their own practice, right? And as the physician, you're still leader of the care team, which is kind of how I think it makes sense to describe it that way. But you have a care team. A physician can't survive by themselves. They need nurses, social workers, financial counselors, and of course your pharmacist and the advanced practitioners get in there as well. And so when I hear sometimes, and what I'm trying to build around our practices is that there are APPs that are in the opportunity, that have the opportunity to kind of sit at the table. And I think that APPs need to have the structured voice to really be successful in the practice. I think that there's a lot that boards and committees talk about in their meetings where APPs typically aren't invited that have a lot to do with AP practice. Maybe there's new value-based care programs. Maybe the Oncology Care First is going to come up with some new metrics, and you're going to have to think, okay, well, how do we capitalize on this? And you need the APP's involvement, and the APPs often have good ideas and good suggestions, right? Because they're the ones that are going to participate in a lot of these programs. What I hear, I survey my APPs about every year, and we have them rank from like a brainstormed list of things on what improves their satisfaction in their career. And there's always the typical, I want more pay, right? I want to be more competitive with my salary. I want more time off. I get that. And particularly post-COVID, a lot of our practices, we're trying to think, okay, we need to provide maybe a half day a week for the APPs just to settle down and be able to take care of themselves. But what I hear every year is, I want to be a respected part of the team. And when I go to our practices and say, okay, your APPs told me that they want to get paid more, and so we can look at the compensation, look at the external data. We may recommend that you increase their salary. So of course the practice is like, okay, I got to pay more, or I need more time off. And of course sometimes they'll think, well, we're going to lose a little revenue because if we lose half day at clinic. But when the APPs every year in the top 3, and it rotates between 1, 2, and 3, wants to be part of the team, wants to be respected, that doesn't cost anything. That's a very easy move that practices can make to keep the APPs happy. So huge engagement opportunity, and of course increases retention. So we really work a lot on how do we get APPs to kind of have a seat at that table. And so when we continue the process, now you have these APPs. I think there's kind of 4 buckets when we're looking at how do we deploy the APPs, how do we continue to demonstrate this value and of course add to the retention. One is to deploy and hire APPs from an organizational perspective. So it's hard in a big practice for a physician to say, I need an APP for X, and then another physician says, well, I need an APP for Y, and they're different, which is, I guess, in the big picture, we don't want robot APPs, so all of our APPs have some utilization. It's somewhat different. But the point of using APPs in a practice to support, let's say, physicians, so that physicians can see new patients, so that physicians have that joy of medicine as well, right? I mean, why do you need to see every consult and every follow-up and every toxicity question and every triage question? Why can't you have some joy? And so using that kind of top-down approach or organizational approach to determine kind of how we're going to hire APPs, how we deploy them, makes it very successful. Plus, it makes it very equitable because the APPs talk too, right? So why do you get a half day off and I don't? Or why do you have this type of a schedule and I don't? Same thing with training. So we have network-wide onboarding that we send our APPs to, and we have toolkits and things that help at the ground level, at the site level. So it's not left to the practices because you guys are busy. And you don't need to worry about how am I onboarding this APP. If you don't do it well, and a lot of times if it's a physician, maybe a solo physician that's onboarding their own APP, if they don't do it well because they have lack of capacity and bandwidth, then usually that's not successful. A lot of times then the doc will just say, well, just scribe for me because I don't have time to teach you. And now you have a real expensive scribe that's walking around following you around, right? And that APP is probably not going to stay there long. And I think evaluating the APPs are important. We hear all the time in our practices, the APPs say, I wish I would get feedback. I never hear how I'm doing. What do I need to improve on? So we work a lot on how do we have conversations with our APPs to their direct manager, which, by the way, in a lot of practices is not an APP. So it's difficult. It adds to the challenges when an APP reports to a nursing director or an administrative person who's neither a PA or nurse practitioner or pharmacist. And so there's sometimes a disconnect on really how do I evaluate you? And then the physicians sometimes have some input, sometimes they don't. But I think creating the opportunity to evaluate and provide direction and feedback for the APP certainly continues to increase retention. And then having APPs have that leadership voice, I think is important too. So if we look at APP roles, I mean, there's two big buckets altogether. There's three here, but we lump two together. From an organizational perspective, ways that we increase physician productivity, access, reduce days to a first appointment are offloading direct patient care. So you see the list here, as well as offloading some of the administrative tasks. Since APPs are going to pick up some of the administrative tasks, another reason why we can't just look at a spreadsheet of their direct revenue, because they might spend 30% of their day doing some administrative heavy lifting so that the physicians didn't have to, which is great. So then you're really only monitoring maybe 70% of what that APP provided. And to use that 70% as the gauge that, well, you're not successful as an APP is probably not a good direction to go. And then think of on the right side here, all these additional services that the APPs bring that are services often that the physicians aren't providing. And so now we're adding services from a patient perspective. We're improving the patient's experience, and we're providing the services, things like survivorship and genetics and things that they need, and you need to help practice as well. I'm not going to go over all this slide, but you can see that there are a number of challenges. It's not so simple, right? I can stand here and say, oh yeah, organizational decision, put them at the leadership table, and onboard them all together in one group. And you're like, okay, well that seems like that's challenging. And it is, and there's a lot of challenges as you can see. My favorite, and you'll have access to these slides hopefully, or take pictures of it and you can read the details later. My favorite diagram on here is this top right physician APP partnership. And really the solid line is happiness, right? So on the left of this, you have a decision that made to hire the APP. Everybody's happy. The physician and APP are happy. They're starting to work together. The physician quickly is like, I'm not sure what you can do. I don't know what the expectations are. I'm not sure what your background is. Are you a new grad? Have you had experience? So the physician starts to get busy, a little bit behind with the training, and then the APP is also uncertain if they're new. And of course, we try to give them the pointers and the help from our corporate perspective and say, here's what you should be doing, and we'll help support that. But if we don't get involved, it just spirals out of control where you have a physician that's not sure, an APP that's not sure, then a physician who thinks that the APP is incompetent because they're acting like they're not sure, and then the APP is now really upset that the physician's not happy with them and they don't say anything, and you can see it just goes out of control, and then we hit that bottom. And usually about month 6, by the way, is when new hires are at the highest risk of leaving, is because by then they're credentialed with enough payers, at least have their NPI, and they're out seeing more patients without a mentor, preceptor, or physician kind of at their shoulder, and they get kind of overwhelmed. And so I hinted a little bit about, are the current metrics that we're using adequate to value our services that the APPs are providing? And really, why is this important? Because we need to be able to prove from a business case that was one of those challenges, right? So we need to be able to show, if you're hiring an APP, you may need to have to do to support that. The CFO and the controllers are going to say, and the practice leadership may say, okay, we're going to hire APPs for over $100,000 in salary and benefits, and where's our return on investment? Why is it important? How are we typically measuring value, which again, most often today in a lot of practice is just direct revenue that the APPs provide, and then what can we do that's better? The barriers of why using current metrics of just revenue from the APP and why that's challenging, as I mentioned already, about 30% of work that APPs provide isn't even billable. And this is an older stat from about 2013 or 2014, so I thought, I wonder if that's still the case. And so I surveyed a number of APPs through our network, and it ranges from maybe 15, 20% to 50 or 60%. So we have some genetic providers. A lot of our NPs and PAs are providing those services in place of a genetic counselor, and the prep and the time on the insurance and the paperwork is awful. I mean, it's a lot for them. And so we think, okay, we need coordinators, we need other people to help out. But 30% is still a good average even today. Now, we also, as APPs, typically don't control our schedule. So if you're going to value the APP based on the revenue they bring in, but we don't, new patients typically aren't being referred to the APP, and we only have patients on our schedule when you see them as physicians and establish the visit and establish that relationship and then say, you're going to follow up with the APP. And in practices that still struggle with that, then the APPs can sometimes not be busy. So we really can't hold that against them. It's not really the APP's fault. However, we do challenge those APPs to be more vocal, right? Go to their practice leadership, go to those physicians and say, I only saw 5 people today, you saw 30, there's some disconnect here. I should be seeing 15, 20 along with you. And then some of the billing challenges. So when you bill incident 2, in a lot of the, so speaking about like back office software, if you're billing incident 2 and you're billing under the physician, then a lot of the work that the APP provided often gets hidden. Now there are certainly a lot of ways to still count the work that APP provided, but when you're looking at just from a charge capture perspective, it usually has a physician's name, and the check from the payer has the physician's name. And so how does that make it look or undervalue the work that the APP is providing? And even split shared services in the hospital, which by the way, over the next year, this year and into next year, are going to make it more likely that the APPs are going to bill under their NPI. The split shared rules are going to be changing in such that way, which is actually a good thing, I think, because then it's going to continue to add charge capture under the APP. And even value-based care services that the APPs are leading, so doing survivorship clinics, doing advanced care planning, they take a lot of time, and they can probably see 2 or 3 sick people, right? Two or three on-treatment patients during that time. But it's important to add the survivorship and add the advanced care planning, not only for patient satisfaction and needs, but also to satisfy your quality scores, which could lead to shared savings and other opportunities financially. So really, where is the value? Is number one, how do we increase capacity and how do we measure that? So if you're looking at an APP on a dashboard and you're looking at the spreadsheet of the work that they've provided, how do we also on the same spreadsheet say, yes, but the physician was able to see X more new patients or X more operations or X more patients under the beam, whatever metric you need, right? So how does that value the whole practice as a whole? Where's the time savings? So we do a lot of these calculations for our surgeons and rad-oncs. We'll say, yeah, your APP is going to be doing a lot of global work. So on a spreadsheet, they may have 0 collections, right? They're doing post-op care. But you were able, as a surgeon, to not see any of that. So you saw, again, from a capacity perspective, but we also calculate it from a time perspective and say, you get 500 hours back per year every time you have an APP doing some of that work for you. And then what do you do with that 500 hours? And we do a couple of calculations to give them some samples of that. I mean, if they take 500 more hours of coffee breaks, that's what they want to do, that's fine. But we do give them opportunities to show, well, if you see consults, if you scrub in, here's what your payer mix looks like, we can help provide that. Value-based care obviously is important for our APPs and our practices, and providing those services, while necessarily maybe not lucrative compared to doing 4 or 5 toxicity visits during the same time, but you can see a lot of value to the practice. A lot of these are also AP-led, and so when you get the APs involved, get them leading these programs, have them develop a survivorship clinic, have them develop a bone marrow clinic, have them develop genetic services. Whatever the interests are that you have some gap, have the APPs lead it, and then invite them to those tables that they're serving in those committees, they're presenting to the board, and they're interacting. And then really from a life-work balance is the bottom line in all of this when we talk about value just now as providers, right? Can we go home at night and not take our charts home to finish? Can the physicians go home and see their family? Can they have that admin time? Can they do whatever they need to do? And we have docs that want to teach, and they just have no time to go to the academic facilities to do it. Well, this gives you some time to do it. So it's all about development for everybody, physicians, APPs, and everyone involved. So definitely that's what we struggle with, and a lot of our practices struggle with, is really how do we continue to evolve those roles, and how do we get that data so that we can show there's value in adding APPs and keep that retention. Our turnover is still trends pretty good overall, but of course with COVID we had a lot of APPs that decided that it was time to move on, whether retire early or move on into other specialties because of kind of the overwhelmingness that they kept having in their field in oncology without having any really time off. And so I think that's another big issue. So I ran a little bit over 20 minutes, a short 20 minutes, a lot of material to talk about. I'll answer any questions if there's time. I may get chased off the stage because there may not be, but I'll be hanging around a little bit if you have any thoughts or questions. But thank you so much for your time this afternoon.